Hello everyone, myself Dr. Ashok Kumar. I am an endocrinologist practicing in Panipat, Haryana. Today we will be discussing about a case in which patient is having established cardiovascular disease and regarding the decision making in the treatment. So my patient is Mr. AB. He is 53-year-old corporate executive. He was diagnosed with diabetes 6 months back. So when he came for the routine checkup to us, he complained of the weakness. His family history was positive for the hypertension and myocardial infarction. He was a heavy smoker for almost 30 years. He quit smoking roughly 5 years back, and he's been trying to lead a healthier lifestyle since then. There is history of previous MI 3 years back, and when we did a physical examination, we found that the weight of Mr. AB was 92 kg, his height was 5 feet 8 inches, and the BMI was 30.7 kg per meter square. So he was obese as per the criteria of the BMI. His BP was 40 by 90 millimeter of mercury, 140 by 90 millimeter of mercury. Labs revealed HbA1c of 8.4%, which is not under control. LDL cholesterol was 137 milligram per deciliter. HDL-C was 37 milligram per deciliter. His triglycerides were 156 milligram per deciliter and eGFR was 65. Urine albumin creatinine ratio was 50. So this is microalbuminuria. Now the drugs which Mr. AB was taking, he was on metformin 1 gram twice daily, which is optimal dose of the metformin. He was on telmisartan for the hypertension 40 milligram once daily. He was getting atorvastatin 10 milligram once daily for dyslipidemia. And for hypertension, he was on getting amlodipine 5 milligram once daily along with the telmisartan for the hypertension. He was getting aspirin and clopidogrel, which is 12 antiplatelet agent therapy. Now, coming to the management of this patient, we need to follow the patient-centric approach to the management. So what are the points that we need to keep in the mind when we are designing a treatment for Mr. AB? Well, we need to go for the patient-centric approach and we need to look into the cardiovascular protection. That is one. Second, microvascular protection, that is the prevention of the microvascular complications of the diabetes, which is triopathy, neuropathy, nephropathy, and retinopathy. And the weight reduction, which eventually may translate into the metabolic benefits. And obviously, we need to reach to the glycemic goal without any hypoglycemic events. And dosing should also be convenient because our patient is a corporate executive, so his lifestyle may be a bit erratic also. Now, primary consideration is the cardio protection and optimization of the glycemic control for the cardiovascular risk reduction and addressing the weight-related issues because he is already obese. Now, what we can do by adding a SGLT2 and DPP4 combination, these desired effects can be attained. Now, I will not say that this is the first time, but if we consider each and every aspect of the diabetes management, now after in the recent guidelines, no agent is above, no agent is below, but yes, we need to decide the therapy according to the background of the patient, associated comorbidities, and what guidelines say that depending on the presence or absence of the comorbidities, we can devise or design the treatment of the patient. Now, by adding SGLT2 inhibitors and DPP4 inhibitor combination in our patient, what benefit we can derive is that we can derive benefit in terms of the cardiorenal protection. The regime will be simple because it's a once daily FDC, fixed dose drug combination, early and durable achievement of the glycemic control to the tune of more than 1%, which as per the UKPDS was a significant reduction of the HbA1c to achieve or to prevent the microvascular complications. Now we need to keep into the mind weight loss also, and the lesser risk of hypoglycemia is also there with this combination. Cardiovascular disease is a leading cause of morbidity and mortality in adults with type 2 diabetes mellitus, with its onset estimated to occur 12 to 15 years earlier in those who are without diabetes. Now, this excess risk of the ASCVD, atherosclerotic cardiovascular disease, in patients with type 2 diabetes have been estimated to be at least twice than those of the normal population who is not having diabetes. What data we have from the Framingham Upstream study, in which almost 2,000 subjects were studied, it was found that almost two-thirds of the patients with the diabetes mellitus had subclinical cardiovascular disease. So diabetes mellitus increased risk of the subclinical cardiovascular disease by 4.34 and with the odds ratio of 4.33. So let's not go into the statistical details, but yes, obviously it is very much clear that the ASCVD or CAD risk is more in patients of the diabetes, and that includes the overt ASCVD and the subclinical cardiovascular disease also. Subclinical cardiovascular disease increased the risk of the CV events by twofold. The vascular wall in a patient with diabetes is well known to have advanced atherosclerosis in comparison to the normal counterparts. First, now the EMPA heart study. The effect of the EMPA on cardiac structure, function and circulating biomarkers was studied in this study in patients with type 2 diabetes, and it was found that EMPA resulted in an early and significant reduction in the left ventricular mass regression, and it was detected by the cardiac MRI during this study. And it was also suggested that there was reverse in the cardiac remodeling due to the possible contribution of the cardioprotective. It is probably one of the contributors to the cardioprotective effects of the SGLT2 inhibitors. In 2015, one landmark trial was published, and this trial was EMPA-REG outcome. And what this study demonstrated that there was a significant benefit of the EMPA for the CV mortality to the tune of almost 38% CV events, as well as MACE in type 2 diabetes mellitus and cardiovascular disease. Now, all types of the CV death were reduced with the EMPA. More prominent absolute benefits were observed for the heart failure related deaths and the sudden deaths. So this is one important finding actually. And the effect was not in short term. This benefit was derived in the short term therapy. So what we can say that definitely there is a clear cut benefit of the SGLT2 inhibitors in patients who are fragile from the cardiovascular point of view. A post-hoc analysis of the EMPA-REG demonstrated consistent CV mortality benefits irrespective of the prior CV events, MI or stroke, heart failure burden, CKD, baseline HbA1c, control of the multiple CV risk factor or background use of the metformin. So this was found to be sort of independent of the other factors. Now, what are the mechanisms that could be behind this whole benefit which we are getting, which we are driving from the SGLT2 inhibitors? This may be probably related with though there are many hypotheses, it may be related with the osmotic diuresis and natriuresis leading to the PP reduction, decrease in the stiffness of the arteries and the vascular resistance, decrease in the weight, though reduction of the weight may not be a promising theory, and decrease in the uric acid and oxidative stress. These are the proposed hypotheses which are proposed for the benefit which we derive from the use of the SGLT2 inhibitors. It has been reported that the SGLT2 inhibitors promote the reverse cardiac remodeling as shown by the EMPA heart study, improve myocardial anesthetics and filling conditions, reduce LV left ventricular wall stress and mass, and reduce the BP and arterial stiffness. EMPA heart cardiology 6 studies demonstrated that the EMPA could produce early reverse cardiac remodeling in type 2 diabetes mellitus and patients who are having stable coronary artery disease. So this was the finding which revealed by the EMPA heart cardiology 6 study. Now another class of the agents, that is the DPP4 inhibitors, which are found to have conflict data when it comes to the heart failure and cardiovascular safety. So what was found that in the trials Carolina and Carmelina, linagliptin have demonstrated CV and renal safety, and secondary endpoints of the linagliptin versus placebo or active comparator when added to the standard of the care in the patient with the type 2 diabetes. Those patients who were having high risk of the vascular complications, so linagliptin have established us. We are having evidence in favor of the lina when it comes to the demonstrated CV safety, CV and renal safety. Now the EMPA-lina, this combination is available for the treatment, and the SGLT2 inhibitors and DPP4 inhibitor combination, it is found to be having some synergism in few of the conditions. Like for example, the SGLT2 inhibitors raise the level of the glucagon, while the DPP4 inhibitors reduce the level of glucagon. So there are so many factors, so many things in which they try to balance out each other. And obviously both, since the insulin secretion of the DPP4 inhibitors is dependent on the glucose levels, so risk of the hypoglycemia is less, while the SGLT2 inhibitors, their effect is dependent on the blood sugar levels and the renal threshold. So again, if we are not using the insulin or the insulin secretagogues, which are sugar independent, then the risk of the hypoglycemia is lesser with this combination. But at 24 weeks of the Empalina combination, it was found that there was a significant reduction in the HbA1c in comparison to the comparator to the tune of almost 1%, when the HbA1c at the baseline was 7.99% as an add-on to the metformin. And HbA1c decrement with the Empalina combination, that was 25 mg of the Empa, 5 mg of the Lina, have demonstrated almost 1.81% reduction of the HbA1c, where the HbA1c at the baseline was on higher side, that is to the tune of more than or equal to 8.5% at the 24 weeks. Now what we can conclude that the combination offers a suitable component of the treat strategy to achieve the target HbA1c without hypoglycemia and additional risk of the weight gain in patients who are having high baseline HbA1c, together with the cardioprotective benefit in these patients. So obviously we need to go with the patient-centric approach, and we need to consider all these factors when we are searching a second agent after the metformin. So this combination have got some promising effect or promising data when it comes to the patients who are having cardiovascular risk profile, which is unfavorable. So thank you. It was nice to interact on this session. Thank you.